Hello, everyone. Thank you for having me again. I'd like to present on occult tethered cord syndrome and some of the vignettes in the research, as well as in patient management, clinical presentation and outcomes, and new findings on the physiology of the spine and the spinal cord based on the occult tethered cord syndrome. I'd like to thank the organizers of the conference, the American Syringomyelia Chiari Alliance Project, and Dr. Grant for inviting me again to give a talk. I'm pleased to acknowledge that the first most relevant description of occult tethered cord originated at the Duke University Medical Center here. And it was Dr. Warder who, together with Dr. Oakes from the Children's Hospital of the University of Alabama, presented 13 out of 73 patients that presented with classical tethered cord syndrome. However, the conus was at the L1, L2 level. And those children deteriorated and were offered filum sectioning and responded greatly after filum sectioning, and the statement was made that tethered cord syndrome may exist in a normal positioned conus. This is a table from the publication from 1993 that shows that Dr. Warder and Dr. Oakes meticulously categorized the symptoms in OTCS. And they described that besides lower back pain and lower extremity pain, patients presented in the categories of lower extremity weakness, bladder and bowel dysfunction, and also the neurological finding of spasticity and hyperreflexia. So they were the first, basically, that acknowledged the triad in occult tethered cord syndrome, which is an important clinical biomarker. And I come back to that later, because in our study that was just recently published in Journal of Neurosurgery Spine, we could replicate exactly those neurological biomarkers as a predictor of surgical success in filum terminalis sectioning in occult tethered cord syndrome. Looking at occult tethered cord really makes you look deep into the pathology and pathophysiology of the filum terminale. And that is what I'd like to present in my talk, presenting the rationale or the findings that explain why a patient with a normal lying conus can still present all these neurological symptoms of tethered cord, where biodynamic and pathological studies have shown that basically occult tethered cord stems from an elastic failure of the filum terminale to buffer stress and strain due to ultrastructural damage in the filum collagen. And then also, in terms of managing or approaching the patients, our recent publication had shown the work of the past 10 years, where a combination of patient-reported symptoms plus finding of upper motor neuron dysfunction in the neurological exam support patient selection and also surgical outcome prediction. We touch base on 1-year outcomes and reported complications. And then also at the end, I'd like to present that the filum probably has a physiological role and is not just an anchor or a tail, but also is involved in an integrated network of all the spinous neuronal networks, where it serves as a mechanoreceptor and also as a pain receptor and gives feedback to the spinal cord motion and the movement of the spinal cord within the spinal column. We performed biomechanics studies in the surgical specimen of the filum terminale in both patients with tethered cord and patients with occult tethered cord, those where the conus is at the normal level. And the studies were done at the Brown University Biomechanics lab, where we tested the stress-strain profile of the surgical specimen, as shown here in that picture. Stress-strain studies have been performed actually largely in muscle tendons, and it has been shown that the best elastic capacity of a ligament is when the stress-strain profile is linear. And the linear relationship in the muscle tendon is lost at a strain above 6 to 8%, where then ligaments suffer from collagen microfibril damage and rupture, and they lose the capacity to buffer any further strain, and maximum stress is applied at that higher range. It's interesting that in 2016, Belgic neurosurgeon, Dr. De Flo, has studied biomechanics of the filum terminale in cadavers. And you can see here that the stress-strain curve looks exactly like those in tendons, which also loss of elastic capacity at a 6 to 8% of strain, showing that the filum terminale technically acts as a tendon. And then our research studies at Brown shows that in tethered cord patients, the stress-strain relationship is largely dysfunction, where the filum loses its elastic capacity already at a stress of 3%, which technically shows that the filum is mechanically overused or mechanically challenged. And that is even worse in patients with occult tethered cord syndrome, shown in the red line. Biomechanic findings are supported by our ultrastructural findings of collagen microdamage. On the left, you can see transmission electron microscopy of the collagen microfibrils. And in the lower portion, you see disarranged collagen fibrils, swollen fibrils on axial cuts, as well as corkscrew fibrils, which are kinked fibrils. And it's been shown in muscle tendons that such kinking of the collagen microfibrils is due to mechanical overuse, which supports our biodynamic findings. On the top, you can see normal aligned collagen, and you see the large difference. And then on the left, on the right, you can see histological studies showing inflammation or inflammatory cells in the filum terminale, for example, mast cells, macrophages, and lymphocytes, findings that are actually also found in diseased tendon, and our filum pathology is equivalent to a tendinopathy. Understanding the mechanisms of a tethered cord syndrome in a normal line conus and its pathophysiology and pathology is certainly validating for the existence of the occult tethered cord syndrome, I would say. However, what is also important is to identify clinical biomarkers, those that help us to identify who would eventually benefit from surgery and who would be a good candidate. And as with any studies, there are flaws and limitations, but what we at least would have liked to accomplish with our study was to encourage thinking about the importance of patient-reported symptoms and trying to categorize them in the triad, into the clinical triad of occult tethered cord syndrome, and then find the important biomarker in the neurological exam, just as Dr. Warder has encouraged this together with Dr. Oakes. And that's what I'm going to present in the next slides. Before doing that, I just want to briefly mention that patient-reported outcome measures in spine surgery have been acknowledged in a very interesting systematic review in 2022, where the authors advocated for increased use of patient-reported outcome measures in spine surgery in both the research and clinical setting. We went on to understand what are the clinical parameters or clinical biomarkers of patients with such a diseased filum terminale, and did a prospective observational study on 149 adult and pediatric patients diagnosed with Occult Tethered syndrome who were treated by filum terminale excision. We included patients with the symptom triad, including leg and back pain, urinary and bowel symptoms, and lower extremity neurological symptoms. And patients had to demonstrate progression as well as resistance to medical management, and a non-neurogenic bladder was excluded by study-independent urologist, and as stated that Occult Tethered syndrome was diagnosed if the Conus level was above L2-3. In our novel study design, for the first time, we focused on patient-reported symptoms and lower extremity neurological findings, and therefore used a comprehensive symptom questionnaire. As you see on the right, from that comprehensive questionnaire, we extracted the 5 most prevalent symptoms and signs in each category: the neurological scale, the pain scale, and the bowel and bladder scale. And the table here shows the 5 most prevalent findings in each of the category, and we validated with confirmatory and exploratory factor analysis that in fact tethered cord syndrome is described best and most effectively by these 3 categories. And when we looked at the main clinical indicators of this triad, we found that pain in leg and back, conus dysfunction, and spasticity, both described clinically as leg fatigue and also bladder spasticity, all those 3 combined identify best the tethered cord syndrome. And the neurological exam truly showed as the most relevant finding increased tone in the lower extremities, often asymmetric, lower extremity hyperreflexia, often with extended reflex zone in the patellar reflexes, and a foot clonus. And that is consistent with upper motor neuron dysfunction or cortical spinal tract dysfunction and damage. What we did is we dichotomized the outcome into responders and non-responders based on change in the 15-item scale score. If there was an improvement by 1 point, we deemed that a responder, and you can see here the responders are in blue bars indicated at the 3 months outcome and at the 12 months outcome. And you can see that the higher the preoperative 15-item score, the more likely it is that you are a responder. You see higher proportions of responders plotted on the higher pre-op scores. Also, with logistic regression, we indicated that a higher score also predicts the likelihood of improvement. If you have a score more than 6, you have a 60% chance of improvement, and a score more than 9 out of 15 gets you up to 80% of likelihood of improvement. The ROC curve shows high sensitivity and specificity, and we could accurately predict the outcome in one way or the other in 82% of patients. So the key findings of the studies were that in addition to conus medullaris impairment, Occult Tethered cord syndrome presents with upper motor neuron dysfunction as evidenced in the clinical exam, with finding of spasticity and self-reported leg and muscle fatigue. The item scale validates the symptom category of tethered cord, and the novel scale helps prediction of outcomes based on the preoperative scoring. Here you can see our post-op changes at the 3 and 12 months mark, and I'd like to present them in the 3 categories or 3 subscales. You can see the most promising results are in the neurological subscale with maintained improvement at 3 months and 12 months. And that includes the leg fatigue and the paresthesias. Also promising the bladder subscale improvement, however, not so much in the pain subscale, which we discussed is likely due to our crude way that we assessed the pain, as we didn't use a Likert scale, and then also the 12 months outcome regarding pain might be affected by many comorbidities. The past 10 years, only 10 studies really looked at the complication rate and reported them. All retrospective cohorts, and 9 out of 10 studies were in pediatric patients only. And what was reported on was on the CSF leak or pseudomeningocele rate, wound infection, and also retethering rate, mainly in patients with fatty filum. And you can see here that the numbers vary. In our own most recent surgical consecutive cohort, we categorized the complications as short-term, long-term, and need for reoperation. And you can see overall, it seems like in occult tethered cord surgery, complications are in the single digits, lower single digits, and acceptable. Of course, with occult tethered cord surgery, the main concern is the symptomatic cauda tethering that occurs pretty much as a natural healing of the arachnoid, where cauda nerves can attach to the dural suture closure site. Ratio is 6% as of yet, and this can occur within the first couple of years. That certainly needs to be looked at in a more prospective fashion. And the jury is still out there. Finally, we like to present our findings on mechanoreceptors and pain receptors within the filum terminale, indicating that the filum is not just a physiological anchor, but might be involved in the proprioceptive regulation of the spine. Peripheral nerve endings have been well described in the histology of the filum terminale and have been coined so-called nerve twigs. But so far, the physiological role and the understanding has been very limited. Using transmission electron microscopy close to those nerve twigs in the filum terminale, we not only saw abnormally structured collagen fibers, as I have indicated earlier, but we also found so-called Ramak-Schwann cells. Those are nociceptors, well described in pain physiology, and are not myelinated axons that connect to collagen, and mechanostimuli that are transmitted through the collagen fibers translate into pain perception. And along with those Ramak-Schwann cells, we also found so-called Ruffini mechanoreceptors, which are very complex nerve endings, again embedded in collagen, and are involved in mechanoreception and reception of mechanical stimuli. Those findings were very intriguing, and we thought to give evidence to the fact that those nerve endings might actually be functional. And what we did, we performed EMG recordings from paraspinous muscles above and below our surgical site. Say if we went in between L1, L2, we placed EMG electrodes above and below the surgical site into the paraspinous muscles and did the physiological recording and found latency responders from the inferior and superior paraspinous muscles with a 10 to 15 millisecond latency, which indicates a monosynaptic response. And you can see here the responses mapped on our EMG recordings from the superior and inferior paraspinous muscles. The morphological and electrophysiological results basically indicate that there is presence of functional and sensory nerve endings in the filum terminale, and that probably intersegmental dorsal root reflex circuits are the anatomical basis for our observations of an EMG response in the paraspinous muscles superior and inferior to the filum terminale. Most importantly, those superior to our stimulation site. And that, like other spine ligaments, such as interspinous ligaments and intersegmental ligaments, the filum terminale may in fact serve as a proprioceptive element, but may also be a pain trigger and may contribute to back pain, not only in tethered cord, but also in other spine disorders. And with that, and my initial thoughts, the filum might probably be more involved, not only physiologically, but also pathophysiologically in many spine disorders, whether it be degenerative spine disorders or other congenital spine malformations. Thank the audience very much, and thanks for giving me the honor to present today, and congratulations to a great conference.